Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision. Welcome back to another episode of the Rural American Surgeon. I'm joined today by Dr. Kabir Mehta, a bariatric surgeon in Hazard, Kentucky. And he's also a co-resident of mine. We were on chief service together, go way back to Mayo Clinic, Rochester, Minnesota, the days that we all try to block out from our memory. But sometimes it's like that quote from The Office. The bad part about the good old days is nobody tells you that you're in them until they're already over, something along those lines. So anyway, Dr. Mehta, thank you so much for joining us. It's a real honor.
Thanks so much for having me, Randy. It's a pleasure to be here.
Yeah, so let's start with an introduction of you. Tell us about, basically you did general surgery residency at Mayo Clinic, and then tell us about your fellowship and your practice since then.
Yeah, so you and I started residency together 2015. And so we did that residency, had fun, and I stayed on at Mayo for a year of minimally invasive surgery fellowship, where I focused mostly in bariatrics and foregut, and did a little bit more of colorectal during that time. After that, ended up looking for jobs, and there were some life forces at the time that wanted me to be here in Hazard in a relatively rural practice, and so that's what landed me here. And it's my third year in practice now, and this is where I'm at with a practice that's bariatric and general surgery, mix of both, and building more and more on bariatric practice here. So, yeah.
What's your catchment area? I'm seeing that Hazard, Kentucky population is like 5,200 people.
Yeah, exactly. It's a 300-bedded hospital, and it's the flagship hospital of a chain of 13 or chain of 14 total. And so we catch pretty much from all of Southeast Kentucky, and a lot of the referrals come from either the sister hospitals or nearby smaller critical care access hospitals. So we end up staying fairly busy for a hospital that seems to be sitting in a 5,000 population town. Yeah.
Now, do you get referrals from as far as Pikeville?
Yeah, Pikeville has its own medical center there, and they're...
I have a second cousin that's currently a fourth year at Pikeville, so that's why I'm asking.
Yeah. So the population between Pikeville and here gets divided. Yeah.
Okay.
We've definitely had patients come from Pikeville to us. Yeah.
Gotcha. So do they do some bariatrics in Pikeville too?
Yes. They have bariatrics there, and we have bariatrics here. So patients.
And then you've got Lexington, and what else do you have in Southeast Kentucky?
Lexington is the closest university hospital to us. Straight west would be Cumberland. That's another bariatric practice there. So those are some of the bariatric centers around.
Yeah, it's interesting to have a rural bariatric surgeon in my network. So I'm super honored that you've came on. I think this is going to be really enlightening for some of our rural general surgeons. You didn't come from rural America, right?
Yeah.
So last several guests that I have on, and myself included, I'm practicing in my hometown, and it's kind of goes without saying why rural surgery is special to me. But the next question I like to ask is, why is rural surgery special to you? So what were the draws, even if there were financial draws? I want to know about that. And then what else have you fallen in love with, I guess?
Yeah, so it was never part of my vision initially to be in a rural practice. And the draws weren't financial. It was more forces of life that kind of left me with some options that I had to pick from. And a lot of that had to do with visa arrangements with the government to provide service to a rural community. Now, it might have started that way, but it changed very quickly. And what I've come to love about this practice is patients are super grateful. They get good care. You build close bonds with them, and you see them over and over again. You see their families, you see their relatives, their friends. It's a close-knit network, and I love that. The other aspect is it became a little bit of a challenge that I liked to overcome, which was I trained obviously to do some advanced things, and to find a safe way to bring that to the rural population here was a little bit of a challenge. I had to figure out, well, can I do certain operations that I learned to do? Would it be right for them here? Do I have the support if there were other specialties needed, that sort of a thing. So we figured all of that out. I've enjoyed that journey. Now we're at a place where we're expanding our practice here. We're bringing in more services and things like that. So I've loved learning how life is in a rural place, how being a surgeon is in a rural place. So now a lot of what you said back in residency that we used to talk about makes sense. I've lived it now. So
yeah, beautiful. So the J1 visa was primary thing that brought you there.
Yeah.
Yeah.
Mm-hmm.
And then how long have you been there?
I'm going on my third year.
And are you going to move?
Well, I can probably tell you, I just got my extension notice, so we've extended my contract. So
all right,
I'm not moving.
So but you're not obligated to stay anymore.
That's correct. So I'm staying out of volition now. Yes.
Yeah, there you go.
Mm-hmm.
Well, that's cool. What a great story. You joined a practice where they were already doing some bariatrics?
Correct. So a couple of my partners are general surgeons that do limited scope bariatric surgery. They'll do sleeve gastrectomies mostly. And so I was able to come in, bring, gastric bypass, duodenal switch, SADI operations, revisions primarily. Revisions form 25% of all bariatric operations in today's time, and that's expected to rise. So I was able to bring all of that here. Yeah.
Yeah, wonderful. What else do you do outside of that? Anything?
So foregut surgery and then general surgery. So your run-of-the-mill gallbladders, appendix, hernias. So definitely I'm seeing those skin lesions, soft tissue masses, things like that. And because we're doing more of this advanced minimally invasive stuff, if we find stomach tumors and other stuff that previously wasn't able to be served here, we're able to add that now.
Okay.
Yeah.
We're going to talk today for our How I Do It. Why don't we just roll into it?
Mm-hmm.
So the next segment of the show is a How I Do It. We're going to talk about bariatric emergencies because I believe that's relevant for the general surgeon. You're going to get a call from the emergency department, a patient that had a previous bariatric surgery, and they have some bariatric emergencies, and deciding how you're going to manage it. I have a few other questions about your practice as well, and like where you think it's going, maybe how you do a few things. But why don't we start with that? Could you just wax eloquently on bariatric emergencies for a while until I come up with a good question?
Yeah, that sounds fine. So bariatric emergencies, that's I think a relevant topic for a general surgeon, especially a rural general surgeon, because we're going to have these patients that have had surgery either recent or past, and that's different because anatomies in the past used to be different, and these have evolved. But I think the first thing the general surgeon on call in rural America needs to delineate is this emergent or is it non-emergent? And since we have limited time, I want to focus on emergent stuff that they're going to be stuck with handling. And so emergent things, just like other general surgery emergencies, include some kind of gastrointestinal perforation. And most pertinent here would be a marginal ulcer perforation for a gastric bypass patient. Typical risk factors are smoking, NSAIDs, steroids, things like that. A lot of the rural America, I found out, at least in my neck of the woods, they like to smoke. And they quit for some time, but they've been back into it, and that's led to this. If you get a gastric bypass perforated marginal ulcer, really the first thing before you even get into that case is be sure you're familiar with a gastric bypass anatomy. Whether it's, looking up a Google image or looking back at a case that you've done in the past or talking to a colleague, that's a worthwhile effort to be familiar with the anatomy. Similar to how you would handle a perforated peptic ulcer in a native stomach, native duodenum, some of the principles go along the same way. If you're going to handle those things laparoscopic, you're probably okay to handle this laparoscopic. If you're more comfortable doing this open, understandable, whatever you're most comfortable with. The goal is to contain the perforation, wide drainage, and resuscitation, right? So if you happen to see a small marginal ulcer perforation, these typically are at the gastrojejunostomy or just distal to it on the jejunum side of it. If it's a small hole, you can patch it just fine, lay drains. Try to do a distal feeding tube of some kind, remnant stomach gastrostomy tube or a jejunostomy tube would be fine. Preferred would obviously be a remnant stomach G tube. Some patients have had their remnant stomachs removed, and then you're left with a J tube option. And you can choose the BP limb, which most people don't think to be the preferred limb. You can choose the BP limb to place a jejunostomy tube in it. And so that patient, if you've patched the hole, you've laid the drains, and you've placed a feeding access, let them recover, and standard management for pulling the drains and letting them recover, and then they can have follow-up with the with the bariatric surgeon for any further definitive management in terms of gastrojejunostomy revision and things like that.
That's perfect. Let me re-summarize what you said.
Yeah.
Patient comes in, marginal ulcer perforation, look up the anatomy, decide your best approach. I'm doing an open.
Mm-hmm.
Define your anatomy, close and patch the hole, drain, feeding tube in the remnant stomach, unless it's not there, then put it in the BP limb as a Witzel J tube.
Correct. Yeah, that's perfect.
And then afterwards, we're going to keep them NPO until they see the bariatric surgeon?
Well, you can keep them NPO, let them recover. You can do an upper GI study, those sorts of things, and make sure there's not an active leak. And if you think there's not an active leak, you can pull one of the drains or both the drains. Make sure they continue to have their tube feeds, and then have them follow up. Remember, BID, Protonics open capsule or Protonics powder, and sucralfate, those go a long way in healing these ulcers and perforations. So that's important.
So otherwise, though, if the drainage is looking good, I mean, we can start them on clears in a couple days, or how long until you would start them on that, and then
that's mostly dependent on clinical progress. But I would wait at least 4 days or so, 4 or 5 days. We traditionally used to wait all 5 days, do an upper GI study, make sure it's clean, start them on clears, leave the drain in, watch for, hey, you had grape soda is coming out of your drain, not ready yet. So that sort of a thing. But waiting, being on the conservative side, wait a little bit longer.
Okay. I'm going to dig into one more piece of this. How would you prefer for me to patch that hole? What type of suture? And do I use omentum or what?
Yeah, absorbable suture and omentum would be great. You can frequently close the smaller ones. You can close sort of the modified gram patch equivalent, close it and then patch it. If you can't close it because it's too indurated, don't try it, don't rip it, don't make the hole bigger. Patch it, make sure the patch is airtight. You can even do an intraoperative EGD, do a leak test. If your patch is solid, you're going to be happy with it. So omentum would be great. Yeah.
So a mental patch. I saw a picture, I don't like it, of closing the hole and then tying a knot and then using the tails of that knot to just put omentum over the top and tie it. But then it doesn't really patch on it. That's a dumb way to do it, right?
I don't like that myself either. It's not an air seal method at all.
Yeah. So do a stitch over here and then a stitch on the other side.
Tongue of omentum
all the way around and make sure that it's tight. Okay.
Yeah. And tight, but not strangulate it. Don't kill that tongue of omentum.
Yeah, it's going to swell in the next 24 to 48 hours. So just approximate, don't strangulate kind of strategy. Right. Makes sense. And nice. And we're back.
All right.
So next bariatric emergency. Let's move on.
Yeah. So the next one to consider is an internal hernia. So again, you've got a acute abdomen situation. Patient's unstable. Don't need to be alarmed. Don't need to be afraid. Oh, this is a bariatric anatomy. Same principles. Anytime you have a hernia, it's similar to, let's say you have a strangulated inguinal hernia or a strangulated ventral hernia. Your goals are reduce the hernia, resect dead bowel, put it back together. And so keep it simple in your mind. And again, if you're familiar with Roux-en-Y anatomy, you're going to know a Peterson's defect. You're going to know a JJ mesenteric defect. Those are the typical offenders. And so the way this is typically made, the jejunal jejunostomy is supposed to be in the left upper quadrant. If it's not in the left upper quadrant on the CT scan, then you know there's an internal hernia. That's one of the telltale signs. And again, you're going to get in, again, open or lap, whatever's your comfort zone. You're going to run the bowel. You can run it many different ways, but bottom line accomplishes the same goal. Start at the roux limb, run it distal all the way to the ileocolic junction, or start at the ileocolic junction, work your way back. Either way, that's going to be your elementary limb. The other limb you're going to look for is the biliopancreatic limb. So when you find the JJ, run the second limb proximal, and you're going to run it all the way back to the ligament of Treitz. And again, you're going to make sure both of those limbs are laying free of any kind of internal hernias. If you happen to reduce an internal hernia and you do identify it, obviously you make sure to close it. Closing that is a permanent suture material. So use Ethibond, use a non-absorbable V-lock, whatever you prefer. Some people like silk. We've found that silk is not necessarily non-absorbable over, the course of decades, or maybe it's not so great for bariatric patients if they lose more weight. Hard to say, but use a non-absorbable suture for that hernia defect. Aside from that, again, you're going to resect any dead bowel. If you think it's just hemorrhagic, not ischemic, you can watch that. You can do your ICG injection. You could do, some kind of assessment of intraoperative perfusion, or you can wrap it in moist towel, come back to it 10, 15 minutes and see if it's declared itself. So that's how you handle that. And an important thing is not to get pulled into thinking a few things. Your standard, this is adhesive small bowel obstruction, and I'm going to NG tube decompress this patient and going to do gastrographin for these patients. You may have a biliopancreatic limb that's herniated through the Peterson's defect and it's ischemic, or not even if it's not ischemic, it's at least not a part of your alimentary tract. So the contrast goes from the esophagus, pouch, roux limb, common channel, never sees the BP limb. And that's not a pass for your gastrographin challenge. So have to have a high index of suspicion for abdominal pain for gastric bypass patients. So don't ignore them.
Yeah, what a great point. So I'm coming up on 5 years out of residency. Mm-hmm. I have not managed a situation like this a single time in 5 years. Mm-hmm. But yet I'm expected to be able to manage it, right? So some of those things that you're telling me, it's yeah, that makes sense. But literally when you don't think about it for 5 years,
you forget.
Yeah, you can forget. Yeah. So let me summarize what you said again, and then I got a couple questions. So Step one, get access. Step one, NG tube.
You can always do NG tube. Again, if it's not an alimentary tract obstruction, if you have a BP limb obstruction, you're going to have the BP limb distension, the remnant stomach distension, but you're not going to have roux limb distension at all.
Yeah, that makes sense too.
Right.
All right. So step one, get access.
Yeah.
Follow your roux limb from the anastomosis to the JJ. Mm-hmm. Follow your BP limb back up from the JJ to the ligament of Treitz. Mm-hmm. Looking for your obstruction. If it's all dilated, then you got a distal obstruction, and follow it distally to ligament of Treves, basically, and then identify your obstruction. That's just a regular routine, possibly adhesive bowel obstruction, probably most commonly in that situation.
Right.
Reduce your hernia, resect any dead bowel, do your bowel assessment, and repair the defect with non-absorbable suture. Mm-hmm. And that's basically it. I have a question. Do you use non-absorbable suture to close your defects at the initial time of surgery now?
Absolutely. Yeah.
But it hasn't always been done, right?
No, at least at Mayo, or at least at our training programs, absolutely. Everybody closed defects. Everybody closed them with permanent suture. There is some debate, and people that don't close them. There are still surgeons that don't close them. I don't favor that. I'm definitely well into the camp of close every defect, please. Don't let an avoidable problem happen.
Okay. A second question is, go ahead and describe the two defects to us, if you don't mind.
Yeah. So again, we're going to talk about, let's simplify this to an anti-colic, anti-gastric. It's already, we're talking about some terms here. But basically, you've got a pouch made out of the proximal cardia of the stomach. And you've got a segment of jejunum that is going to come up to that pouch. That segment can be brought up anterior to the transverse colon, anterior to the remnant stomach, and the anastomosis could be made that way. And that's an anti-colic, anti-gastric rulem. Now, the mesentery of this rulem will arch over the transverse colon. And so where the cut edge of the mesentery of the rulem approximates the cut edge of the mesocolon, the transverse mesocolon, that space becomes a potential internal hernia space. That's actually a pseudo-Peterson's defect. The Peterson's defect was defined initially when they used to do more retrocolic rulems. And so they would make a hole in the transverse mesocolon, push the rulem through that into the retrogastric space or the lesser sac. And so the defect between the rulem mesentery and the transverse mesocolon and the posterior mesentery or the posterior wall of the abdomen was the true Peterson's defect. So anti-colic, anti-gastric has a pseudo-Peterson's. That's the defect that you want to close.
Okay. And you close that first off, how do you do your Roux and Y?
Anti-colic, anti-gastric. I do them robotic or laparoscopic. Yeah.
Okay.
Yeah.
And you do it both ways, or
you mean
mostly robotic now?
Now it's transitioned mostly robotic. Yeah.
Okay. But you close that defect, so you stitch the transverse colon mesentery to that cut edge of the mesentery
of the
with a
mesentery.
permanent stitch.
Correct. Yes. It's either a V-lock non-absorbable or it's an ethibond. If I'm doing it lap, just the way the technique is developed for me, it's ethibond. If it's robotic, it's a non-absorbable.
What size? You use a 3.0 or 2.0? Okay.
Yeah. And yeah, either way, 2 or 3 won't make a huge difference as long as you've got adequate approximation. One thing to remember in that bite, when you're taking bites on the rulem mesentery, don't take massive bites because you're going to snag the vasculature. But I think that's general sense that most surgeons have anyway.
Yeah, don't hit the middle colic either.
Right.
All right. And then your other defect?
The other defect is the jejuno-jejunostomy defect. So you have a end to side jejuno-jejunostomy created as a part of this anatomy. And so the cut edge mesentery of the end jejunum going onto the side of the other jejunum, that's going to become your common channel. There's space between those two mesenteries, and that's your jejuno-jejunostomy mesenteric defect. And those have almost never been found to be a problem for internal hernias. It's typically the Peterson, pseudo-Peterson situation.
Gotcha.
Mm-hmm.
Thank you. Any other bariatric emergencies?
You could run into a jejuno-jejunostomy intussusception. So when these are made larger, they're implicated triple staple technique of a jejuno-jejunostomy. Make common enterotomy, staple fire proximal, staple fire distal, staple fire close the common enterotomy. That makes for a pretty large jejuno-jejunostomy. You can have an intussusception through that. And that's typically not known to cause your roux limb obstruction. It can frequently cause just the BP limb obstruction. And so CT scan imaging will show you remnant stomach dilatation, duodenum dilatation, proximal jejunum in the left upper quadrant dilatation. May not necessarily be a roux limb and elementary limb dilatation. And so again, NG2 won't be helpful there. Not saying that gastric bypass patients would never benefit from an NG tube. You can easily have a common channel obstruction or a rule limb obstruction that you need an NG tube in, and decompress them that way. But an intussusception, again, you manage it as an obstruction. You're going to go in, find the area, reduce the intussusception, assess for viability. Majority of the times, even if it is viable, you're almost obligated to resect and reconstruct that anastomosis. There are some surgeons that would say, hey, if you've reduced it and it's viable, you can PECSI that segment that's intussuscepting, and create some kind of an adhesion that will prevent it from doing that again. But again, the other faction of surgeons to which I belong, we believe in just resect, redo it, don't make it a super wide anastomosis, and you should be sorted from that problem.
Okay. So can you describe, like, to the level of an intern, how to do the reconstruction, like really in gory detail?
So Roux-en-Y reconstruction or JJ reconstruction?
JJ reconstruction.
Okay.
Because you're saying if there's an intussusception there, it's because it's too big, and the right answer is to resect and reconstruct it.
Yeah, correct. So I'm going to do the simpler explanation. There are some nuances to this. You could have a situation where you could salvage having to transect all three limbs and making two anastomoses, but that's a little bit hard to explain without diagrams or being in that situation. So presume you have a JJ intussusception that you've decided needs reconstruction at this point. You're going to transect. You're going to try to waste as minimal bowel as possible. You're going to transect the BP limb just proximal to the JJ. You're going to transect the Roux limb just proximal to the JJ, and common channel just distal to the JJ. Now that is out of the system. Divide the mesentery as you need to. Now you're going to connect the Roux to the common channel. Whatever's the Roux limb end, connect to the common channel end of it. And again, you're going to do, I don't know how much detail you want to get into, but it's a small bowel anastomosis. Line it up, common enterotomy, staple, close the common enterotomy. You're done with that anastomosis. And then you've got the BP.
Okay, hold on. This is your Roux limb back to, and you're doing this like antiperistaltic side to side, or do you line the two up side by side and do it
probably won't make any difference.
Doesn't matter.
From a functional standpoint. Yeah. You've got good reach. You've got good. Just use your common sense. Make sure it's sitting nicely. It's not going to be twisted, and obstructed in any way.
And you would recommend doing that with a stapled anastomosis?
Staple will be fine as long as you're confident the bowel will hold the staples, things like that. Shouldn't be a problem. Yeah.
And if you were doing it as a stapled anastomosis, and there was tons and tons of reach, exactly how would you choose? Which of those options would you choose? Like, would you fold them in like this so the two ends are together?
Yeah.
Or what?
I would do that. Yeah. If I were in that situation, I would do that. It's side to side, functional end to end, but it's antiperistaltic side to side.
Yeah.
Not isoperistaltic.
Yeah. So then you would you place a stay stitch before you make the enterotomies?
Exactly.
And you're talking about being laparoscopic or robotic while you're doing this?
Yeah.
Do you think?
Yeah. I mean, I always start exploring lap or robotic depending on robot availability, training of this crew after hours. But let's say I'm doing this lap, explore this lap, run the bowel, find the intussusception. Let's say I reduce it. I want to redo this. So I would create windows, mesenteric windows at the mesenteric borders of the bowel. Staple across, all three limbs. Yeah. Then I would do stay stitch, exactly what you said.
Yeah.
Stay stitch on two ends. I typically like to make those two cut ends face the camera. And so if the camera is coming in from here, you're looking straight down the double barrel. Yeah. And so then you make common enterotomy, staple.
How far apart are your stay stitches?
Typically 5-6 centimeters. So, and to that effect, since we're talking about stay stitches and going into depth of this, the stay stitch on the end where you're going to close the common enterotomy, make that close to the mesenteric border, make your enterotomy close to the anti-mesenteric border, staple it, because you'll realize the common enterotomy reaches deep in towards the mesenteric border. If your stay stitch is up towards the anti-mesenteric border, you're going to have a hole between the stay stitch and where you're trying to reach to close the common enterotomy close.
Okay, let me go say this. Make sure I got this. You're going down toward the mesentery on the inside to place your stay stitch.
Yeah. So if you've got two ends, cut ends like that, right?
Yeah, right.
So your stay stitch should be closer to the mesenteric border.
Yeah, on the inside. So it sort of folds it out a little bit.
Correct. Let it fold out. The distal one you could place on the mesenteric border, anti-mesenteric border. It doesn't matter.
The reason for doing that is why?
Is to close the common enterotomy. When you've made both enterotomies and you've fired the stapler, the common enterotomy, the deeper end of it, will get close to the mesenteric border. If your initial stay stitch was close to the anti-mesenteric border, you're going to be in a situation where you either have to cut that stay stitch to completely close the common enterotomy, or you're going to be struggling trying to. But
when you actually make the holes, you make it perfectly anti-mesenteric.
I do it anti-mesenteric, yeah.
Yeah, and you make that. So then we've placed these stay stitches, which are what stitch? A silk?
For me, it's silk, 2/0 silk, yeah.
2/0 silk, and they're 5 centimeters apart. And now you make an enterotomy on each side with hook cautery.
Yeah, I usually have a harmonic with me just because I have to take the mesentery. I'll use that harmonic to pinch a little bit of bowel, cut it open. Yeah.
Okay. And then you're bringing your stapler in, and it's a what kind of stapler?
I have Ethicon here, but if you've got Medtronic, whatever you've got, tri-staple pretty much. And so white load for bowel for me on both of these. And
so white load, not tan.
Yeah, white load for Ethicon is one of the thinnest, and that works well on bowel.
Okay. And then so do you know the staple height on that?
I believe the closed staple height for that is 1.2 millimeters. I forget. But it's essentially their equivalent of a vascular load.
Okay.
I don't believe they go any thinner than the white load on the Ethicon.
Okay. And then you haven't had any issues with a delayed leak because it's too tight or anything like that?
No, it works great. Yeah. The white load on the bowel.
And you have less issues with bleeding probably with it then?
Correct. Never had, knock on wood, never had bleeding, never had leaks on those. So, yeah.
I don't want to jinx you or anything, but it's small bowel anastomosis usually goes well. We all know that.
Yeah.
All right. So then you fire that stapler, and what's the length?
So you use a 60, and I don't necessarily use all of that 60 millimeter length. I use maybe 5 out of that 6 centimeters, and that's plenty. Yeah.
Okay. And then you have a common enterotomy, and how do you deal with it?
Just close it with Vicryl, and that's a running stitch for me. Dunk the mucosa. You could do a canal. You could do anything you want. Just make sure it's nicely approximated. You don't need to do an outer layer on it if you're happy with how this is approximated, well vascularized, those sorts of things.
Okay, if you're going to do a single layer running Vicryl, that's a 2/0 Vicryl? A laparoscopic single layer with the 2/0 Vicryl, and you're not canelling it, you're just running it. Baseball. How did you start it? Is your knot on the inside?
No, start the knot on the outside. So you're starting on the most anti-mesenteric border. And you're going to go down to your stay stitch. Your stay stitch, again, has to be well exposed. The entire otomy has to be well exposed. Your stay stitch is...
You're starting your stitch maybe 5 millimeters past where the enterotomy starts, would you say? Yeah,
5 millimeters past, tie a nice knot, and then you take your first bite and just take one bite on each side. Yeah.
Okay, and then you run it all the way. I've been doing the second layer for all this time, and it's totally pointless, you're telling me?
Well, again, do what helps you sleep better. Again, there are people out there that do single layer gastrojejynostomies also. I couldn't give up the second layer of the gastroj. I still do 2 layers everything, other than that one common enterotomy closure. It's just what we learn, right? You just develop comfort with it, and you know it works.
Yeah, that's where experience comes in. I mean, training and then experience. My listener is essentially myself. So first off, but it's one person that's listening at a time in their headphones as they're exercising, as they're driving in their car. And by the way, I appreciate you for being here. And, I want to ask the questions and dumb it down as much as possible because the things that are intuitive, they just get sometimes glossed over. So thank you for going to that level of detail. Now, you're going to make another anastomosis. Where do you put it relative to that that one you just made?
Yeah, so great question. I would want to do two things. One, make sure you've measured the length of the rule limb now, just because you've had to resect some. And some of these older anatomies were shorter rule limbs. Make sure the rule limb is at least 70 centimeters in length. Majority of the times, you're not trying to get this patient more weight loss. So remember that. And then you're going to make the second anastomosis, make it, we're going to say, distal to your rule limb to common channel anastomosis. You could make it distal. And make it, I say that because you're going to divert bile distal to it. If your proximal anastomosis leaks or something like that, at least bile's not flowing through.
Yeah, there's less flow from across the other anastomosis. Makes sense.
Right. And make sure the rule limb length is 70 centimeters. And again, there are multiple ways you could do that, Randy. So for example, if you gave me a patient, I've had to do this for, let's say, common channel reconstructions or lengthenings, the rule limb lengthening, the BP limb lengthening for more weight loss for these patients, gastric bypass patients. And there are two things. Think about it this way. If you did RU to common channel anastomosis and then you plugged the BP limb somewhere, you've not changed the elementary limb length for that patient. Let's say you had a patient that had a short common channel. You measure their common channel after resecting for an internal hernia, bowel ischemia situation. They're left with, let's say, 100 centimeters of common channel. Okay, you've got 50 centimeters of rule limb. That's a bad situation, right? So in that case, what I would say is borrow the BP limb. Use the BP to common channel anastomosis. Do that first, okay, and then hook your rule limb up way proximal onto the BP limb. Yep. Therefore, you have prolonged
your common channel.
Exactly. So you can use those things. So you can make these in any order. Just let it make sense to you.
Yeah, if that doesn't make sense, like hit the rewind button and listen to that a couple times because it's a little mind bending, but that makes sense.
Yeah.
All right, great. So say that you've got plenty of length and you've got 70 centimeters of. You're talking about from the ligament of Treitz to
rule limb 70 centimeters from the gastro J to where the BP joins in.
Okay. Got it.
The issue is bile reflux. If you way back in the day, I want to say, don't quote me on this, but I want to say early 2000s maybe, or maybe somewhere in the 2000s and before. The rule limb length used to be 40 centimeters at some point, 40 to 50 centimeters at some point, and that's too short. We found out because the bile goes retrograde into the pouch and can cause bile reflux into the esophagus. And that's a pretty bad problem for patients to deal with.
Yeah, makes sense. Yeah, right. You don't want to redo this again.
Yeah.
Okay. So then you say you have plenty of space. So would you say it's most common that most commonly you're putting it distal to that anastomosis you just did. So then you bring it down, you lay your cut edge. This will be a isoperistaltic to the common channel.
Yeah.
And then you do essentially the exact same anatomy. You're looking on the end of the cut edge of your BP limb. And you put 2 stay stitches and you use the same staple load and you close the common interotomy with the running 3-0 Vicryl single layer baseball stitch.
Sure.
And then what do you do with the mesenteric defects?
Close them again. So you use some kind of permanent suture, Ethibond or small bowel mesentery. I don't worry too much. On occasion I've used silk, but some kind of permanent suture for mesenteric defects.
Would you leave a drain in that situation?
Small bowel anastomosis, if you were doing this with not much edema, I wouldn't.
Would you do anything with the omentum?
Wrapping the omentum and things like that, really not for small bowel. I just make sure it's covered up. So if you ever have to go back in, the bowel is not stuck to the anterabdominal wall. And that's the most I would do with that. Yeah. One quick point on anytime you do a end to side BP to common channel anastomosis and you're going to close the common enterotomy. Your common enterotomy can create, if you take big bites, you can cause a rule limb obstruction because the rule limb is entering into this anastomosis and if you oversew that too much, you can have a narrow entry into that wide BP downstream, if that makes sense.
Yeah, that could be. I could see that being hard to treat without a redo.
Correct.
Okay. Anything else we're missing here on bariatric emergencies or this particular one? I know what I'm going to do when I find myself in this situation.
Yeah.
I'm going to go to the ruralamericansurgeon.com and I'm going to go to the show notes where this is all going to be transcribed, and I'm going to read it and I'm going to say, oh yeah, that's what Kabir said to do. And I may call you too. So very good.
Yeah. Call me anytime. Well, bariatric emergencies is obviously a very wide topic, but we just picked a couple common scenarios. You got a perf GJ or you've got a internal hernia. So we tried to touch on that. There's resources out there. One thing you could do is have your listeners join some of these private surgeon groups. They're Facebook groups. They're private, as in they're not open to public and patients, but they're open to surgeons. And so SAGES has a number of groups, and join these groups. There are so many great videos that come out. Acute care surgery has a group.
Is that what you're going to propose for the resources for the busy rural surgeon segment?
I am. There are so many of these groups.
Why don't we jump ahead and tell me either your favorite for bariatric? I guess that's probably number one for a rural surgeon, and then if you have others. Yeah.
Well, don't I say this at the cost of being judged. I upload.
That's everything I say, man.
I upload a lot of operative videos. So I have a YouTube channel. Just goes over robotic or laparoscopic cases. So I'm one of those people. I don't always want to watch TV. If it's not sports, I'm watching somebody's operative videos and I want to see how they do it. So that's something. But I pitch into the Facebook groups that I was mentioning. So SAGES has a lot of these groups: SAGES Acute Care, SAGES Bariatric, SAGES Colorectal. Same thing. You've got robotic surgery collaboration. You've got these Facebook groups. You don't think to learn on Facebook that much, but people are posting their operative videos. It's fantastic.
Dude, my Facebook algorithm has me so dialed in that I had a post the other day about somebody purchased a Highland cow and flew it home in their PC-12 Pilatus aircraft. And I'm like, okay, the only thing that was missing is like, they should have been doing surgery on the cow or something like while they were flying. But that's like,
there you go.
I mean, it got me figured out, but I have a lot of surgery stuff that comes up. It's basically like surgery stuff, inspirational stuff, a little bit of sports stuff, like some spirituality and then there's cows like everywhere.
Yeah. That's good stuff, man. That's a good lineup.
And what is your YouTube handle?
It's Kabir Mehta, MD.
And we'll put that in the show notes so you can just go check it out. And if you have any questions about how to do that anastomosis or, you want to try some of those techniques out, feel free to check it out and incorporate it into your practice. I think we need to keep moving. I had one more question that I really wanted to ask you, and this is a personal question. So, there's a lot of obesity in America in general, but especially in rural America. And I just don't have it in me. I'm sorry to, there's the Center of Excellence and there's all the pre-op work that has to go into bariatric surgery. And so we've kind of been taught that. I'm not sure how much of that is actually relevant. But my question is it appropriate for a rural general surgeon to be offering a sleeve gastrectomy without also offering a Roux-en-Y gastric bypass? And maybe part B to that question is, what do you really have to do to really be doing your due diligence and doing the patient right for your pre-op, post-op things, should a rural surgeon offer that?
Yeah, I would say realistically, in that situation, you won't be able to do justice. Rural general surgeon.
Somebody that didn't do a bariatric fellowship.
Right. So depends on how many sleeves. Did you do enough sleeves in your general surgery residency? there's ways to complicate a sleeve gastrectomy. There are so many ways, and hardly any of them end up without a second operation or multiple operations down the road. And so the first thing is, be sure that you can at least technically be confident and say, I can technically perform this operation without causing complications. And now the question is, should I do it? Do I have the resources? So then we come to the next aspect of it. Is there adequate pre-op counseling? Can you educate the patient? Can you make sure you'll follow the patient, make sure they're not going to be vitamin, mineral deficient, those sorts of things afterwards as well. And then you're going to worry about, okay, if I run into a situation where there's a complication, what are my backups? There's a leak, is my only option to go to the OR and then operatively drain them, do something with the sleeve, or, hey, I'm not, equipped to handle a complication here without IR, without, let's say, GI help, those sorts of things, then that's to be taken into account. And the one other aspect that shouldn't be forgotten is, again, if you're not doing Roux-en-Y gastric bypass, you're not doing SADIs, you're not doing the duodenal switches, are you truly able to provide the patient a comprehensive list of alternatives? That's part of informed consent, giving them, hey, not everybody has to have a sleeve. I've heard of plenty of surgeons that they have sleeve in their armamentarium. It's a hammer that they have, and they treat everything as a nail. And that's not fair to the patient. I've also heard the rhetoric being given to the patient say, always start with the sleeve. It's the least disruptive. True, it's the least reorganization of your anatomy, and that's fair. But is that the best operation? Could you have?
Not if you have reflux.
Certainly not if you have bad reflux, and gastric bypass is the answer. But also, diabetes, for example. You're trying to hit diabetes. Somebody has a BMI of, let's say, 55. They have diabetes, recently diagnosed. They don't have reflux. SADI is a great operation for them. That's going to give them the most bang for their buck. One operation, they get rid of diabetes, the best chance they can have, and they're going to lose more weight. They're going to keep the weight off because weight regain is less of a problem with that. So my point is, can you have that fair conversation and have the patient make the right decision, that sort of thing. So there's so many barriers. I feel the answer is going to be no to your question. But in a very select situation, capable surgeon has done surgeries, can provide the education, can provide a good consent, can take care of them post-op. Yes, in a very select small situation, you could probably.
Yeah, I mean, it sounds like you would have to do it essentially under somebody at a center where complications could also be transferred too, because there's that. Right. But maybe outreach surgeon too, who's already doing full complement somewhere else. Right. There's a lot of little nuances. You never say truly never, but the answer is basically no. So I like that. Thank you very much.
Yeah.
All right. The next segment of the show is called the Financial Corner. And I was wondering if you had a money tip for our listener.
Well, if they've been listening to your show, I'm sure they're all tuned up. I doubt that I'm going to bring anything to the table here. Randy, you were one of the most, judicious, smart, and, you planned everything out. I have simple money tips. Don't be afraid of finances. A lot of doctors, they don't want to manage finances. They'll outsource it. They'll pay hefty amounts to financial advisors that are essentially abusing their naivety or lack of experience. It won't take you a whole lot of time to just come up with read a book, or not even read a book. I mean, White Coat Investor is a source that a lot of doctors use. You've probably given them great advice. There's a few tenets. Just spend a little bit of time. You will be so grateful to yourself down the road. That's the biggest thing I want to say. Don't be afraid of managing your finances. It's not that complicated.
Yeah. So I love that. And I don't talk about stock tips on here. All right. And I don't tell people I can tell them what I've done, but I don't say you should do this specific tax strategy or whatever, because I'm not an accountant. And I kind of believe that. I think that you should basically, if I would summarize what you said, I would say educate yourself.
Yeah.
Because again, like podcasts, we're not a financial advisor, we're not a fiduciary, this is for your entertainment only. That stuff is all true. But at the end of the day, like save some of your money and don't spend it all. Maximize your earning opportunities, seek a gain, try not to lose money, educate yourself. Those are the kind of principles that we mostly talk about on here. And mainly, I've seen so many like, brand new surgeon, $700,000 house. It's just like, we don't need to do this. Let's make sure we're pigeonholing some money away so that something happens. Actually, I've got a story for you. So I don't know how much I've talked about this on the show, but man, I got an allergy to now I can't get any more disability insurance because I just said this on the show. All right. So because it's out there, I got an allergy to gloves. So
latex-free gloves, and you've got an allergy still?
Yes, it's a accelerant. It's actually a somewhat more common thing. I don't think it's that common, but there's an accelerant in rubber gloves, non-latex, that I was allergic to. And it was like last year at the end of 24, it was insane. My fingers were getting like this red, beefy red rash, like throughout all of them. It actually started when I went to Honduras. I had one tiny little thing on the back of my hand, and then I just kind of like limped myself along. I thought it was maybe like a weird fungal thing and then I ended up having my nurse practitioner shave them off and send them in, and it said atopic dermatitis. But then I made this stupid mistake. I put myself on steroids, PO steroids, right? It completely cured it. It completely went away. I took off the steroids, and then my hands just erupted. And so don't do that. Then I got this beefy red rash, like it was mostly on my operating surfaces, like the sides of my fingers where I was tying down my knots and stuff.
Sure.
And like where I was running my scope or whatever. And long story short, I ended up going to Mayo Clinic and I did patch testing. And they put like, I don't know, 200 little aluminum discs on my back with a bunch of little stuff. And I was allergic to the accelerant of surgical gloves. It's a common enough thing. And Mayo's a good enough place, I guess, that they had like truly a pre-printed flyer about this, typical Mayo form. These are the gloves to avoid. You need to get, I think they're called Gamex gloves that I got. So I switched them. Now I'm much better, but like when I'm operating, it's still like tingly, and there's a lot of new skin that's growing back. I still have deep crevices, but I mean, that's very stressful. And so why I'm talking about this in the financial corner is because first off, get yourself some disability insurance as soon as possible. Make sure that it's own same specialty or whatever. So like
true own occupation,
true own occupation. And it seems like, you can't afford it, but you can't afford not to, because what you want to insure against is only financial catastrophe and nothing more. So you don't need, you need liability insurance for your car. Okay. Because if you get in a wreck and 4 people die, that's financial catastrophe potentially for you. Plus it's probably legally required in a lot of places, but you don't need to insure your car. Right. Because that's not a financial catastrophe if you just had to buy a new car. Like maybe for some people it is, but it shouldn't be. Otherwise, you're driving too expensive of a car relative to your net worth. But you don't need to insure, like when you're going through the line at Walmart, your new whatever technology gadget, because it's not financial catastrophe if it breaks. And you don't need to insure your vacation, but you need to insure your life. Up to a point until you don't need to anymore, when your net worth is where it needs to be. And you definitely early on in your career need to insure your hands as a surgeon.
Yeah, I completely agree. And so that's what I was going to say. If it's going to be expensive, it is expensive. But you can have, let's say you're going to insure yourself for $10,000 post-tax dollars or $15,000 post-tax dollars, whatever you're going to insure yourself for. You could have 2 policies. You could split that amount into 2 policies, keep both for the first 7, 8, 10 years of your life. After that, you've got a nest egg. You've got some kind of a fallback pot. And so you can drop one of those policies and you could still have the lower one. And so definitely have disability insurance. I agree with that wholeheartedly.
Yeah, that's a great tip. And it puts a little like what's the word, more like it makes you feel mortal when you buy your disability insurance, because you're thinking, okay, I'm buying this until I'm whatever 60, 65,
Yeah.
the payment,
Yeah.
which means, oh man, like you don't think about this I didn't think about this when I was a resident, but each case that I do, that is a part of my body of work that I'm going to do as a surgeon, which is finite. There will be a number at the end, and this is a small percentage. And so, like along the way, you think, hey, when am I going to be at 10%, 20%, 30% of my practice is over, or I'm at the end? And I found that little thing insightful when I was buying my disability insurance.
Yeah, definitely insightful. On the topic of insurance and talking about catastrophes and things like that, umbrella insurance. Again, I'm not an insurance agent. I don't like to overinsure myself. That's a cheap insurance. That adds maybe 10, 20, 30 bucks to your insurance bill per month. But that one covers if your auto is maxed out, house is maxed out, or some other weird thing happens. Somebody comes to your house and gets hurt somehow, or
right.
Whatever, that covers you for a big amount for a very small fee. So,
do you have an insurance agent?
I do have an insurance agent that gets me disability insurance. Yes.
Mm-hmm. But do you get your umbrella through an agent, or do you just get it from the company?
Separate. That's through my home insurance. I also added the umbrella policy to that, and so. You bring that up because there's an extra fee for the agent, or?
No, I moved actually to preferring working with an agent.
Yeah.
Because they kind of know my overall picture.
Yeah.
And then I feel like they can negotiate me better rates. I feel like if I ever have to do a claim, I just call them, and they help me out through it. And my time is now worth so much that while I agree that managing your money, you need to educate yourself, I don't really think that you shouldn't have a financial advisor either. Yeah. You need to decide on your own. Yeah. But for something like that, it's like having an accountant, having an attorney that you're paying for some advice, and they condense your learning down. Like, I don't want to read about the insurance, it's not worth my time to do that. And especially for insurance, they're like kind of commission salespeople, so they're actually pretty cheap for you. So be careful. But yeah, the last thing I wanted to talk to you about is embracing failure. And we learn lessons more from failure than we do from success. And I was wondering if you could share with us your thoughts on embracing failure and what that might mean long term.
Yeah. I think similar to many people, I took failure hard early on in life. And then as time went on, I realized some of those failures weren't really bad for me. They turned out good. And then I was watching this movie this one time, and it had a great little excerpt come up. And it's the Zen Master Will See story. And so the story goes, there's a 16-year-old boy in the village gets a horse for his birthday. Everybody says, "Oh, how wonderful!" And the Zen master says, "We'll see." A few months down the road, he falls off the horse, breaks his leg. Everybody says, "Oh, how terrible!" Zen master says, "We'll see." A little bit time later, a war breaks out. They want all able-bodied men to go to war, and this kid can't go because he had a broken leg. And so then the villagers say, "Oh, how great! You don't have to go." And the Zen master says, "We'll see." The point being, we don't know how something is going to play out for us in the long run. What might seem like a failure today may just be some on a grand scale, some way to redirect us from one path onto another. One closed door doesn't mean it's a closed door, but it just means you might have to look for a different open door, and another door opens for you, and you just keep going down that path. And so, don't take it too hard. Just give it your best effort. Have some intentions, have some plans, but don't be married to the outcome. So yeah.
What's the most dramatic example of that in your life? Personal example.
One time that particularly stood out. So I'm doing my rotation. This is at This is in Boston at Harvard. So this is the time, sub-I rotations, you kill yourself, right? You go to lengths. So I'm waking up every morning at 3:30, getting to work at 5, just however I'm doing this. I'm biking in 20 degrees weather or 30 degrees weather outside. So the night before, I try to go to bed early, try to keep be rested, things like that. Night before, the guy I'm splitting the room, the apartment with, is going through something. I try to help him out, and we end up staying up pretty late. So I fall asleep pretty late, and I don't hear the alarm the next morning. These are surgery rounds. You can't be late. You're completely irresponsible if you're late. So I'm late. The team tells me, well, why don't you just go to clinic today? Don't worry about rounds. Don't worry about this, that, or the other. I say, okay, fine. I'm already not feeling great, right? I'm not doing good. So then I find out the shuttle goes to the clinic building at 9:30. I'm like, all right, I'm in time for that shuttle by all means. So I'm standing at the shuttle area. It's 9:25. I'm like, okay, I've got a minute. I'm going to go pee because I got to go pee. So I go pee. I come back. It's 9:28, and I'm waiting. The shuttle doesn't arrive. It's 9:45. Find out shuttle came and left in those 2 minutes.
Oh.
So no, I can't make it to clinic that day. I'm like, damn it. I'm trying. I'm here at 9:28. What's happening? And because I missed that shuttle, now I was forced to take the day. What I did with the day was I was going to reach out to people for feedback, reach out to, do something with the day. And that leads me to send an email to Travis McKenzie. He's a fellow at Brigham at the time. He says, yeah, would love to meet you. Why don't we meet for lunch? And so I meet him for lunch. He says, yeah, glad you emailed because I'm leaving for Rochester today and I wasn't going to be back. And I would have flown back that day to India. So I have that one meeting with him. He becomes my mentor. Whoa. And he gives me every kind of, training, every kind of advice. He's a philosopher friend. He's such a great guy. Forever grateful to him, Travis McKenzie. And lo and behold, he becomes one of my biggest supporters. I get to Mayo Clinic and I get such great mentorship from him. And that wouldn't have happened if I didn't sleep late that night, didn't miss my alarm, didn't miss the bus left too soon for its time. Hey, but the mindset was, hey, I'm just going to do the best I can with whatever I've got. And it just led to a tremendous outcome for me.
Yeah. It turned something terrible into something great. That's insane. What a story. No. And yes, what a mentor, Travis McKenzie. And that's just serendipitous. I can't believe it. Or providential. I believe providential, actually. But.
Yeah, I don't think Travis knows that story. So
he doesn't. We're going to share this with him. He's got to know, and he needs to come on this show too.
Yeah, he truly does. Yeah, you should have.
He's from Alaska.
Yeah. Oh, yeah.
Talk about rural.
Yeah, that's right. Yeah, Alaska. Okay. You had a guest here that's from Alaska.
Yes, practicing in Alaska, trained at Mayo Product.
Yeah, there you go. Yeah, you had a whole episode on that.
Yep, and she's got quite the practice up there too. So
that's awesome.
We can put a link to that in the show notes as well. And then I've got a little story of my own. Maybe I don't want to take away from what you said, but the same thing has happened to me probably multiple times. Probably happened to everybody. But I didn't actually want to go to college when I graduated high school. I didn't really know what I wanted to do, but anyway. Long story short, I ended up going to Purdue just because my buddy was going there, and I chose pharmacy because I had to choose something. I didn't want to be an engineer, and they had a good pharmacy school, and the series of conversations basically led to that. And then ended up, I had 4 semesters of declining GPA and didn't get into pharmacy school after 2 years, right? There's 1,000 pre-pharm and 100 of them get in. So I watched all my classmates switch to easier majors, and then I got very mainly motivated by spite to not switch to like hospitality, And so I went in, I remember going in and telling my healthcare advisor, whatever, academic advisor, like, I'm going to med school now, because I was so mad. And they're like, don't do that, man. You look at your grades, look at your trajectory. This is not going to be a good solution. I'm like, no, it'll be fine. Cause I knew, I was not trying at all. Like I was sleeping through my exams and stuff.
Mm.
So then I switched majors and got straight A's and then got, 99% on the MCAT. And then I was confident enough to I applied again the next year to pharmacy school, got in, and then I went and like turned them down. This is like my great moment as an immature, almost still teenager, and then moved on. But I mean, that was still a pretty low, not getting them. That was like the first thing that I tried and didn't succeed at, was getting into pharmacy school. But it was, of course, that was the right thing. Like I would be miserable as a pharmacist. And discovered completely my passion and calling. And it just, but you could never have gotten me out of high school and said, okay, you're going to go do 13 more years of training. Like it was enough to, like 6 seemed like too much already, Yeah.
Well, I can say this world's a better place with you being a surgeon. And to your listeners, I want to say this very loud and clear. Randy was hands down probably the most driven person at Mayo Clinic when we were there. And he always was, looking for cases, looking for work to do. The guy was never free. And a hardworking guy, driven. And when I found out he's doing this podcast, I was like, sure, of course, Randy be found doing this among 10 other things that he's going to excel at every one of them, So, tremendous guy. Randy, I think we both align on this one thing, which is, I think you and I both like setting goals and working towards them and achieving them. And I know everybody does that in some sort of a way, but so far, at least in life, it hasn't ended for me. I'm still thinking, okay, what am I going to do next? And I see you and I see that you've already done the next thing and the next thing. So that's awesome. And I love that. And I think your viewers are benefiting from this and a lot of people will. So.
Well, thank you, Kabir. That is the nicest thing I think anybody's said for quite a while to me. So I really appreciate it. And I mean, that was a brutal time, but it was a fun time. And you look back on it, the further and further you get away from it, the more you actually enjoy it. Yeah. But cranking out those cases, I mean, it was great training. And it also is you don't realize how much like, we're all just surgery residents, right? So we all seem we're the same as the next guy when we're all, there's like 50, 60, general surgery residents there at a time. And they're all just kind of lumped together and you can see like differences between us, but it's kind of like many things. We're more similar than we are different. And compared to the general population, we had this very unique shared experience, and all of those people, they're doing incredible things in the world, and what you're doing is insane. So I love, and Hazard, Kentucky, what a cool place. Like to say that, I've got this person we did chief residence, service together, and he's a bariatric surgeon serving Southeast Kentucky. Like, I love it. So
thank you, man.
Thanks for what you said, and thanks for what you're doing.
Yes. All true things that I said. And no, it's been a pleasure and honor. And, for a moment, I thought I wasn't going to be able to do the breadth of surgery that I learned, the complexity that I learned at Mayo Clinic. I wouldn't be able to do here because of the limitations of the hospital. But it's worked out great. The hospital's worked with me, and so now we're doing, will you believe this? We're doing modified duodenal switches. We're doing revisions. We're doing everything that I was doing at Mayo Clinic, I'm doing here. And so that's for me, that's the ultimate thing. Am I doing everything that I can do for patients? So
yeah. How many bariatric surgeries are you doing a year?
Last year I crossed 50 bariatric surgeries. This year we're on track to cross a lot more. It's looking like a much bigger number this year. So I don't want to count my chickens before they've hatched, but it's looking like a lot bigger number than that. So
so every week you're doing a bariatric surgery though, in a town of 5,000.
Yes.
Well, 52 weeks. That's how I came up with that math. But
no, that's fair.
On average.
Obviously, there's weeks that I'm on vacation or CME or on call, that sort of a thing. So, but no, the number's gone up for a lot more. I think I'm going to hit that number probably before it's half of this year. So.
That is so awesome. Cool. Well, I am so thankful for you and your time that you can share this stuff with us. And we will share these show notes on the ruralamericansurgeon.com. So if you trigger that in your head and you want to come back even in an emergency situation, I don't know if that would be helpful to anyone, but it will be to me. I'll put it that way. So thanks again. I really appreciate it. It's great talking to you, Kabir.
Thanks very much, Randy. It's been a pleasure. And I hope to see more of your work and your shows on this podcast.
And if this is helpful to you, listener, in any way, please don't forget to give us a review, like us on Facebook, share this with your friends. We're trying to create a rural surgeons sort of surgeon lounge in a sense so that we can talk about some of these things that nobody else knows about. So thanks again for being here, and we'll see you on the next episode of the Rural American Surgeon.
Oh, just so you know, we're going to plant maple trees when we get home.
Show them the maple trees. Okay, we got to do them. Sorry. The send out. We're going to plant maple trees. Charlotte's excited, and she wants to share it with the whole world. So we got some that grew up in the flower garden, but we're going to try to keep them alive. All right. See you later.